Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak to Dr. Kelvin Baggett, the COVID czar for the city of Dallas, Texas. Dr. Baggett is a graduate of the Johns Hopkins Bloomberg School of Public Health and a former leader of large health systems, who now works in alternative investing and private equity. We speak about the role of COVID czar and the situation in Dallas. Let's listen. Dr. Baggett, thank you so much for joining me. You are the COVID czar for Dallas, Texas. What is a COVID czar?
Thank you, Josh, for having me. I must say that knowing some of Russian history, the term czar struck me as not being something that I wanted to necessarily attach to myself. But Mayor Eric Johnson of Dallas asked me to take on that title because he wanted to convey not only the magnitude of this particular situation, the COVID-19 pandemic, but also to convey that I had the full support and authority from his office. And so that's why we came to that czar term. My responsibility is to use my skills, experiences, background, a network, relationships, whatever those pieces may be, to reduce harm and suffering associated with COVID-19.
Now, Dallas does not have its own health department. It relies on the health department for the county. The city of Dallas doesn't have its own health department, and you have different health systems. You have, major businesses, universities. Is part of your job to bring all that together?
It is. You're right. Dallas is one of what I understand may be one of the few cities in America that does not have its own public health authority.
Few big cities, at least.
Few big cities, yes. They contract with the county, the Dallas County Public Health Department, to provide those services, and so that has been an experience of it in and of itself. Understanding that relationship and recognizing that you don't have direct authority over those public health resources during a time of public health crises. You're also very much correct in that we are fortunate that we have a lot of healthcare systems that exist here, some national systems that have a footprint here as well, but they have operated, as you would expect, independently. And this is, of course, a time when collective action is necessary and some distribution of management capability and capacity is also necessary to make sure that we're prepared to counter the virus. So that has been part of the role as well.
So how do you do that? I mean, how do you get these very different types of organizations together and to see a common goal or work on common projects?
Well, fortunately for me, I guess, is that I assumed this position after we had recognized that truly this was going to be a significant crisis. So there was already some degree of awareness. With that, there had already been some degree of conversation between the various systems as well, and some loose coordination of efforts in a way that would promote the health of the city. What I did was help to utilize my background in some of these systems that are represented here, as well as my understanding of kind of how you might best operate in a crisis to bring them even closer together. And not only to bring the hospitals together, but also other entities.
So what have the key priorities been for you?
Well, the first thing was making sure that we understood the magnitude of the problem. And so we broke it down into detection. How good are we at detection? And then the other pieces were, how are we going to act in terms of prevention and health promotion? And so with detection, the thing that I was asked by the mayor to look at initially was to see if we had any disproportionate impact. As you know, there's a lot of national data that shows that people of color have been disproportionately impacted by COVID-19. So evaluated that, found that yes, indeed, that was the case here in Dallas, especially and specifically for the Hispanic population. And then looked at testing and how good we could get and how rapidly we could deploy increased testing capacity. And so we focused a lot on what we call our neighborhood-based testing strategy to make it more accessible. In terms of prevention, have been working with the county's health department to improve contact tracing. We're still far behind where we need to be in that regard. And health promotion have worked very aggressively on a communications and outreach strategy.
Great. Talk to me a little bit more about the inequities. Do you see your work as narrowly limited to the COVID testing, or are you looking more broadly to some of the reasons behind the inequities that are there?
I'm looking more broadly, and partly that is due to the fact that COVID has uncovered so many things that have been long-standing systemic inequities and disparities. And so we're addressing the emergent issue of COVID-19 with a recognition that some of this disproportionality that we're seeing in terms of those who are having higher degrees of mortality and hospitalization is due to the fact that they've had limited healthcare access. They have, in many regards, lower health literacy. They don't have environments that would help to encourage or support greater health behaviors. And therefore, this not only gives us an opportunity to address it, but also has, I think, helped people to recognize that ignoring those things puts not only individuals at risk, but also our entire community.
And is that a message that you think is maybe penetrating more than it had previously?
Yes, it is. As somebody who's spent a fair amount of my time and career trying to engage in efforts and conversations around social determinants of health, what I can say is one of the benefits, if I could say that, out of COVID-19 is to be able to shed a light on that and to have more productive conversations around that than I can say that I've ever had before.
So you're both engaged in the nitty-gritty of how many cases do we have, where's the testing, but also what's behind the patterns that we're seeing, and can we get a little bit deeper to prevent some of these problems?
Yes, I am. And what's been very helpful is that I think in the past, people may either have not been aware of it or may have ignored it because they may have thought that it did not affect their individual health. It did not affect their individual circumstances. And what COVID has helped, I think, most to better understand is that we are interconnected in such a way that if it impacts someone else's health, they could potentially spread it to you. And now with, I think, a national conversation around essential workers and how vital they are, that their health is also of concern.
So we're talking now in mid-July. The COVID situation's not so great right now in Dallas. Cases are growing. The hospitals are filling up. There's a tremendous concern that it'll just keep getting worse for a little while, or if not, it'll stay bad at a level that is very difficult. How's that discussion going now? I mean, you started at a time when maybe there weren't so many cases, and now, I know you've been talking quite a lot about how vigilant people have to be, and how's that changing the way people are perceiving your message? What do you think the future has in store?
What has happened very recently is I was advocating for mask wearing. We've now gotten more advocacy around it. It's being required in our businesses. So that's a positive. People are seeing these increased cases, and now they're beginning to recognize that perhaps there's some things that they should have engaged in or engaged in more. So that's also helpful. We're being very public and even more vocal around the importance of physical distancing, face covering, hand hygiene. But also with these rising cases, we're seeing us in some ways regress to earlier stages of our reopening. So the governor and local officials have scaled back some of the reopening activity such that people are becoming increasingly concerned that if they don't take some action and adhere more strongly to some of these recommendations, that there could be a likelihood that we could shelter in place. So those things, those confluence of decisions as well as data points, I think is not only raising awareness, but is also affecting behavior in a positive way.
So your basic messages are staying the same, and you're hoping that more people are hearing them.
Yes. And we're bringing them from a variety of sources. What I've advocated for all along is that we need to have different voices who are influential within various segments of our community to speak to them. And we also need to make sure that we have what I've now described as a multi-strategy for communication. And that's multi-generational, multicultural, multilingual, and multimodal so that it reaches far and wide within our community.
Great. Well, I really wish you the best with that at this difficult time. And I really appreciate your taking some time to talk to me today.
You're certainly welcome. Thank you.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.